So welcome to part 5. Today we tackle emergency insulin therapy, where timing, insulin, fluid, and electrolytes as well as precision save lives. So what is FRIII? It stands for Fixed Rate Intravenous Insulin Infusion. It's a protocol-based approach for administering insulin at a consistent rate, usually 0.1 units per kilogram per hour, without a bolus dose unless specifically ordered or indicated. We used it in hyperglycemic emergencies like diabetic ketoacidosis and hyperosmolar hyperglycemic state. The goal isn't just to lower glucose, it is to shut down ketone production, restore fluid balance, and correct dangerous shifts in electrolytes as well as pH. The fixed-rate IV insulin infusion gives us control, predictability, and safely in some of the most unstable metabolic situations we face. So in managing diabetes or diabetic emergencies, it's critical to distinguish between DKA and HHS, not just by laboratory values but by treatment priorities. In DKA, insulin is started early to halt ketogenesis and correct acidosis. Blood glucose is typically above 200 mg per deciliter and venous pH is below 7.3 or bicarb under 15. The main risks here include sodium shift and cerebral edema, especially if glucose drop is too quickly. In contrast, HSS prioritize fluid resuscitation first. Insulin is delayed until after initial volume replacement, usually 1 to 2 liters of IV fluids. The focus is on correcting dehydration and hyperosmolarity. Risk includes thromboembolism and cerebral edema, particularly in elderly and frail patients. Both conditions, however, use the same protocol, the fixed-rate IV insulin infusion, typically at 0.1 unit per kilogram per hour, but timing and goal differ. In DKA, insulin targets ketone suppression and acidosis. In HSS, it's used later to gradually lower glucose and osmolality. Understanding these differences ensures safer, more effective care. Now, when to initiate fixed-rate insulin infusion? When hyperglycemic crisis is confirmed, first we have to confirm the diagnosis, either DKA or HSS. The key triggers include blood glucose above 11 millimoles per liter or 200 milligrams per deciliter. This has been updated since 2024 by the ADA consensus report, and ketone greater than 3 millimole per liter or significant ketonuria and acid-base imbalance, like a venous pH below 7.3 and a bicarb under 15. In DKA, insulin starts early to suppress ketogenesis and correct acidosis. But in HSS, we delay insulin after the patient receives around 1 to 2 liters of fluid. And why? This is because insulin shifts water and electrolytes rapidly, and in HSS, that can be dangerously after osmolarity and increase in the risk of cerebral edema. So while the dosage stays the same, the timing depends on the crisis. Protocol guide us, but physiology sets the pace. So the diagnostic criteria for DKA has evolved between 2009 and 2024 consensus report. Same with HSS. For DKA, the glucose threshold was lowered from 250 milligrams per deciliter to equal or more than 200 milligrams per deciliter. And a history of diabetes can now support the diagnosis even if the glucose is below that threshold. For ketosis, the 2024 updates specifies beta-hydroxybutyrate of equal and more than 3 millimoles per liter or urine ketones of at least 2 plus, replacing vague positive results. Acidosis still requires pH of less than 7.3. Bicarbonate is now optional. Most notably, the ion-ion gap was removed because it is not specific to DKA and can be elevated in various conditions like lactic acidosis, renal failure, or toxin ingestion. These changes promote earlier, more inclusive, and clinically precise diagnosis. While the HHS changes from the 2024 ADA consensus report made HHS diagnosis more inclusive and precise, it allows either effective osmolarity of more than 300 or total osmolarity of more than 320, reflecting renal variability. Ketosis is now defined as beta-hydroxybutyrate less than 3 millimoles per liter or a urine ketones of less than 2 plus, and acidosis requires a pH of equal or more than 7.3 with bicarbonate equal or above 15 millimoles per liter. Lowering bicarbonate to 15 millimoles per liter makes HSS diagnosis more inclusive, especially for patients with mild acidosis or renal dysfunction, while still confirming that significant systemic acidosis is absent. Now, mental status is no longer a required criterion for HSS, recognizing that HSS can present without coma or stupor. These updates support earlier recognition and a better alignment with real-world presentations. Now, fixed-rate insulin infusion is the preferred insulin strategy for both DKA and HSS. In DKA, it started once potassium is stabilized to equal or more than 3.3 millimoles per liter and works to suppress ketones and correct acidosis. In SSS, it should start with fluid resuscitation and focuses on gradual glucose reduction and osmolarity control. The typical dose is 0.1 unit per kilogram per hour but may be lowered to 0.05 units per kilogram per hour in frail patients. Fixed-rate insulin infusion simplifies titration, ensures steady insulin delivery, and supports safe metabolic recovery. Here you can see in table form the difference between variable rate insulin infusion compared to fixed rate insulin infusion. As you can see, the target glucose drop for fixed rate, that's why it's called fixed rate, is every hour you should lower your blood sugar at least 50 to 75 without range of blood sugar. If not, you can increase. If it's lower than that, you can decrease the insulin dose every hour. And in variable, it's variable depending on the blood sugar hourly, and you change the unit according to the protocol. Okay, so it is used in DKA and HSS for the fixed rate and variable rate for critically ill patient. Now, this is an example of fixed rate IV insulin infusion. It is a nurse-driven DKA protocol with insulin infusion given only when potassium is above 3.3 MEQ per liter. That's very important. Okay? One-time bolus may be given if ordered, followed by a fixed rate infusion at 0.1 units per kilogram per hour. Blood glucose is checked hourly and insulin is titrated based on the rate of decline. If glucose drops more than 100 milligrams per deciliter per hour, reduce insulin by 2 units per hour. If it drops 50 to 100 milligrams per deciliter hourly, maintain the rate. If it drops less than 50, and then you can increase the unit by you can increase the insulin by 1 unit per hour. Once glucose falls below 250 milligrams or 200 milligrams per deciliter, dextrose-containing fluid are added to prevent hypoglycemia while continuing insulin to clear ketones. Insulin is only held if glucose drops below 70 milligrams per deciliter, which is considered hypoglycemia. Now, in DKA management using the fixed-rate IV insulin infusion protocol, blood glucose often drops faster than ketones and acidosis resolve, a phenomenon known as glucose-ketone mismatch. This does not mean insulin should be stopped. Instead, it signals the need to add glucose-containing fluid. Doing so allows insulin to continue suppressing ketogenesis safely while preventing hypoglycemia. Insulin is only discontinuous once both ketones and acidosis have resolved, typically when beta-hydroxybutyrate is less than 1 millimole per liter or the pH is more than 7.3 and bicarbonate is more than 18. So what is the guideline says according to 2024 ADA consensus report and supporting protocol? Fixed rate IV insulin infusion start at 0.1 unit per hour of regular insulin. The goal is a steady glucose decline of a range of 50 to 75 milligrams per deciliter per hour. If glucose falls to slowly, or let's say less than 50 milligrams per deciliter per hour, the insulin rate may be increased. If glucose falls too quickly, more than 100 milligrams per deciliter per hour, the rate may be reduced or dextrose added to prevent hypoglycemia. This range is also supported by the Joint British Diabetes Society's DKA guidelines, which recommend adjusting insulin to maintain a safe and predictable glucose drop, avoiding cerebral edema or rebound ketosis. So, the difference between variable rate versus fixed rate IV insulin infusion is highlighted here. The fixed rate use a fixed hourly dose adjusted only if glucose falls outside the target drop of 50 to 75 milligrams per deciliter per hour. Some journals will tell you 70 to 100. So variable rate IV insulin requires hourly recalculation based on current glucose level. So the fixed rate IV insulin infusion is preferred in DKA and HHS for consistent ketone suppression and simpler protocol-driven care. So, patient with DKA and HHS can be transitioned from IV to subcutaneous insulin once they show clear clinical improvement. And in DKA, this means resolved acidosis with a pH of more than 7.3 bicarb of more than 18. Ketone cleared and blood glucose is less than 250 or less than 200. In HSS, serum osmolarity should be less than 320, mental status normalized, and glucose less than 300 milligrams per deciliter, or both. The patient must be alert, eating, and have stable hydration and electrolytes. Always overlap IV and subcutaneous insulin for 1 to 2 hours to prevent rebound hyperglycemia. So these are the key takeaway. In the fixed rate IV insulin infusion, a bolus dose of insulin is not required if the insulin is started promptly and potassium is above 3.3 MEq per liter. Fixed rate IV insulin infusion begins at 0.1 unit per kilogram per hour, again without loading dose, and bolus is optional, maybe in severe DKA with high insulin resistance. In DKA, it start early to stop ketone formation as long as your potassium is adequate. In HHS, you delay insulin until after you instituted fluid, so you focus on osmolarity and hydration. In ADA 2024 consensus report, it's updated criteria for earlier, more precise diagnosis. And there is a mismatch alert in DKA management using IV insulin infusion, that glucose may drop faster than ketones. So in order not to stop insulin, you have to add dextrose or D5 containing fluid. So lastly, transition safely. Wait for clinical as well as biochemical stability, and overlap IV and subcutaneous insulin for 1 to 2 hours. So with that, this wrap up our session on fixed rate IV insulin infusion. Up next is the last part 6, the key transition in hospital hyperglycemia management, such as from no insulin to IV insulin, both protocol, the variable as well as fixed rate, from IV to subcutaneous, both in critically ill and non-critically ill patient. Number 3, from a sliding scale to scheduled sub-Q insulin as a transition. And lastly, from hospital regimen transition for discharge plan. And for that, again, I would like to thank everybody for listening.